All right, guys, here we are, episode 7 of the Dental Learning Live. We got a lower anterior. It's actually my second take because the first take did not work, no audio, so it's recorded. Lower number 25. And this is a crazy case because it's been started by the general dentist, and the tooth was just so tender and so swollen, he left it open and punted it to me. And it took about 7 to 10 days after the antibiotics that she arrived at my office, so that's kind of the lead time. So let's fire up Dental Learning Live and show you the experience that transpired. Now when you look at this, one thing when he said he started it, one thing that he did is he did not place a temporary filling. And there's some logic to that. You know, he was worried about back pressure. She was in a lot of pain, and in his experience he says, this is what I do. And I have no problem with that. Did prescribe the antibiotics, and that was that. The idea behind that is let the oral environment sort of buffer any sort of gram-negative anaerobics growing down there and filtering through the system. One of the disadvantages are you're allowing more bacteria in, and food and biomatter can get in there. Now if you look at this cone beam, you can see that this lesion is there. There's a radiolucency that's been there for some time, and when you interviewed her with the history, we knew that this had a history of trauma. There's no carious lesion, there's not an incisal fracture, and so the origin likely was from a traumatic injury a decade previously. So if you roll back the time, she can kind of tell me some stories. Really can't pinpoint what exactly happened, but we know that's the closest we have for why the tooth went necrotic. When you look at that, though, it really has spent some time in there, so I do believe this is a long-standing chronic lesion. When I asked him about how productive it was, the referring doctor, you know, he did get some, he said, but not as much as he would have liked for how big of a swelling it was. And that was the reason for the antibiotics and leaving it open, I should say. All right, so you kind of get the deal here. The GentleWave is ideal for this type of situation, just frankly because these lower incisors, yes, they're spindly, yes, they're hard to access, but a lot of times they're very proud. I mean, the buccal lingual walls are very stretched out and proud, and so there's a lot of space in between them. Now when you look, let's go back there a little bit since I was chit-chatting here, but you can look and you can see that that swelling is right under that kind of the mandibular frenum, and it's just kind of in these two little pockets there. You can see that it's opened, and there is some biomatter in there from the mouth. And so we're going to just get this isolated. You've seen this before. I like using the caulking around the rubber dam. It just makes me feel good. I don't want the patient to taste any bleach. And you can kind of see that access is actually positioned incisally, and that's a good thing, especially for the GentleWave procedure, because they really do have to be incisally accessed just to kind of get the maximum efficacy out of that, the procedural instrument we call the APM. All right, so there's the setup. Now, I'm going right to the apex locator because it's open, and on the x-ray I knew I could pretty much stick my finger in it. I'm not going out the end. I'm taking this kind of down almost to full tone. I'm not doing a patency pullback technique. I'm just seeing that I can get in there and that it is open, and then I can select the instrument that I'd like to use to kind of remove that biomaterial in there. And so because of that mass that's sitting in there, I chose to use a 3D shaper. Kind of is good in the sense of that is a very oval canal, and I want to see what kind of things are going to come out of there. And I'm not quite taking it to length. I'm just sort of debriding it, and then I'm going to irrigate here, see what flushes out. And then after that, we'll run it down to my length. All right. Okay. Now, I don't expect it to be productive based upon that history, but I did have, as I was moving that lip around, you could see the tension that was in there, and then that it had something underneath the gum tissue. So I knew that likely and hopefully maybe there is abscess there, and I'm going to express that through the tooth, or maybe the GentleWave will, through its negative pressure, remove some of that. Now that I've taken that 3D shaper down to length, to that apex locator length, I'm actually going to reposition just a little bit more. I'm going to go a little bit more incisal, and the reason for that is I'm trying to just actually, when I take that matrix of the GentleWave over, the platform over, I want it to really line up properly on that incisal edge, because I want the mechanism of that APM to be right over the long axis of the canal. So I've just moved it and I've kind of dimpled it into that incisal edge, and then you can take a look at that. And that's something that I'm, through just doing these, that I really feel like is a better access with the GentleWave. These teeth are really spindly, and the platform actually is fairly big. So that is something that you kind of have to do. And you'll see how I position it in a second here. So take a look at that access. You can take a look at it through the incisal edge. And what I'm doing is I'm lifting that up, and I'm trying to make it as perpendicular to that incisal edge as I can, and this little positioning guide to be down the long axis of the tooth. Now I'm using a hemostat, and I've switched my hand to my left hand as how I'm positioning it, and I'm just injecting underneath it. I find that with these anterior premolars in this platform, all I've got to do is sort of put the sound seal underneath it and let it just sort of flow underneath the matrix. It works really well, and I'm able to do this in the lower anterior without a mirror, so I've got access to two hands. So I'm just covering that, securing that platform, and just giving it a quick set, just so any sort of hand movements won't dislodge anything. If you notice, this blind side where this hemostats are is always the part that it's harder to get to. So I don't worry too much at this point. I'll just cure it, and then I'm going to come back and reapply to where I know I couldn't get that around and didn't want my hand to move as the tip of the sound seal was kind of starting to tip the platform. So I'm just bringing a different tip that I can reach in there. I kind of just make that tip up. Actually, it wasn't intended for the sound seal, but it kind of has a long reach, so it's easy to kind of put it where I want. And then give it a go, just give it a little like here, and that's all it takes. Sound Seal's very, very forgiving, by the way, so it's kind of nice. All right. Also, if you pay attention to this clock over here, that is the right time. I mean, that's how long I've been into this case. And then a final cure. All right. Now, if you look at it, you can re-access it. You don't have to if you have a nice, there isn't anything in the way, if you haven't had any flashing or any flakes of the sound seal go down. And then when you put, so I didn't, so I chose not to re-access this one. Honestly, a lot of times I do re-access. And now I'm going to go through this degassing phase with a procedural instrument. And if you look right here, this is the dancing bubble, and the design of this is a little bit different than the molars. And so it's actually using, this is actually kind of the impingement plate or the sound bar. It's the stream of fluid that's coming through the procedural instrument hits this, and that's where the cavitation cloud occurs. So we're essentially seeing that, as I understand it, develop right there. And that is where you get Bernoulli's law over current over an empty space. You generate that negative pressure or that lift. And so that's why you want to kind of position that and keep that right on top of the canal. And you don't want it to disappear or to stream like that is. When you see that stream, that's just air coming through. And so I'm obviously getting my hand comfortable, and I'm positioning it during that degassing phase. So there's a little bit of wiggle room just to get your bearings and get that settled in, get the patient dialed in, and I'm trying to get this thing in focus as well, and I'm just going to actually hold it with my left hand and kind of put my fingers under the chin simply so I can focus with my right hand. So that's what was going on there. The sound flow, the sound bar, and the sound results, kind of the acronyms that they're using, the degassing, it's all the same. It looks different, but they've made up for that sound bar to occur like I described inside this procedural instrument. Now, God, I mean, we're 12 minutes into it. That platform build was super quick. Just a few minutes, that's all it takes. Instrumentation was a single instrument. And now what I'm doing is that instrumentation was really to debulk any biomatter, in this particular case of being it left open, but it's just to make a pathway for the fluid. And that's what this is doing. So even though this is showing a molar procedural instrument, the same process is happening. It's creating the same mechanism with the same sound waves, and it's going through under this negative pressurized environment and then doing the disinfectant protocol. And again, this is just going to hover to the best of my ability. That's my job right now. And I like watching that, actually. Now, around that is where the exhaust is occurring. And so, you know, if you see things come up through there, those things could be debris. It could be, if there's a retreatment, maybe specks of sealer or gutta percha. It could be purulence. And honestly, in a case like this, I was kind of expecting to see that. But it could also be heme. And so I find myself holding the procedural instrument and staring out the window and trying to be funny at the same time with my patients. A lot of times I'm not that funny. Most of the time I'm not that funny. But anyways, not a lot's occurring here. And it gets me to think about kind of the time course analysis of this event. I got a decade-old insult, compromised blood supply, I would suppose. That led to necrosis. Maybe it was a form of anachroresis, if you believe in that. Definitely left a lesion in the bone, a radiographic lesion, and so clinically, what is it? Is it an abscess? If it was an abscess, and from the history of the dentist, maybe that's what he called it, and maybe that was the reason for leaving it open, and that was his opinion to me. That's why I left it open, and he called it an abscess. But maybe it's not an abscess. Maybe it's a granulomatous mass that's kind of in that spot, because after all, it's been there close to a decade. And there was components of abscess in that. When I'm running the GentleWave, if it's an abscess and I'm in this negative pressurized environment, I've seen and others have seen that when you have vestibular swelling, it will actually decompress it or drain it. And I would suspect that would mean I would see evidence of that through the window. And as we're running through this, I'm actually not seeing that. And maybe it's by virtue of just leaving the tooth open. But it got me wondering, because if you go back in the video and you watch me stretch and pull the lips, you can actually see the borders of where that pressure was underneath there. And when I felt it, it was fluctuant, but not like an indurated feel, but it's not draining. Now, I did instrument to length on this by my choice. I also noticed if you look at the cone beam and go back in there, there is some radiographic resorption going on from the traumatic event, I would suppose, and from the response of the periapical tissues. So, you know, it wasn't that I went full tone with my apex locator, but I didn't stay a millimeter short, candidly, because I don't know what the heck's inside this tooth. But I'm not getting any drainage. So my mind is now shifting along this journey, on this case, thinking, it's more like a granuloma. But I have this fluctuant swelling. So maybe it's a cyst. Maybe it's trapped. I don't know yet. So we're 16 minutes into the case. The dancing bubble is dancing. Window's clear. You know, patient moves, I move. My assistant's coming around, suctioning up any just sort of human error. And we're running. It's going to run for 8 minutes, and it's going through the bleach cycle, a rinse cycle, an EDTA cycle, and then a final rinse cycle. And you can see my assistant here just, sometimes if the music is really good in the room, she'll start to dance. Sometimes she doesn't. Sometimes she's hangry. All right, so we're getting closer to the end. Nothing coming out. So my mind is then going to address the concept of do we drain or not to drain? And I guess that's kind of the lead-in of the little title of this. Like, how many of you do believe in that? How many of you would say, well, if this thing is not draining, maybe I should just stop, do calcium hydroxide, and bring it back? Maybe there's someone that would make an argument that maybe I should instrument and it's a not a base cyst, but a true cyst, and you lance it, and then maybe you could drain it through the tooth. Or maybe it's none of the above, and even though it was corticated on the bone, I got a soft tissue response, and maybe I want to IND it. And so there's a lot of things to think about, and we're all different. We can kind of chase those rabbits, and we all can make an argument. And I'm going to make my argument here in a minute once this is done and explain why I did what I did. So this thing's going to be wrapping up here. We're 18 minutes into it. You kind of love it when not a lot's going on, by the way, because it's just humming along. Things are very predictable. The patient's very, very comfortable. And you can see how stable this platform really is. And that's one of the things when you get used to doing this way is my advice is you just can't use too much sound seal. Just keep building it up to where you really have a stable platform. So if you have any sort of fatigue, operator fatigue, or the patient's wiggly, it's really predictable and really stable. All right, so 19 minutes, 1 minute has passed from the last time I said that. Our job at this point, although at times you're like, your mind can wander, like mine is right now. At times, this environment, it's really important to pay attention to what you're doing, and it's actually really important that your hand position maintains that bubble, because you can get kind of a little bit sloppy at times. And I would sort of say to you, pay attention. All right, so now that we are done, Lindsay's actually going to, as she's working over there, she's going to move the GentleWave out of the way. She's handing my mirror. I'm taking a look at it. And let's just go ahead and remove this platform, the sound seal. Keep this in focus. All right. And if you look inside here, you can appreciate the internal anatomy matches what we saw in the cone beam. It's kind of got that elongated ribbon shape. And I'm just going to suction out. I'm not getting any bleeding, even after the GentleWave. It's definitely clean in there. I can't see anything caught in there. I'm going to go ahead and do a rinse just to check. And since it wasn't, I actually grabbed hypochlorite as opposed to hypertonic saline. And it's clean. Went down to my length, but like I said, nothing's coming out. So my mind is saying, okay, well, I'm going to dry and obturate. That's where my comfort level is, and I kind of trust what transpired there. Some of you may not. Some of you may want to use calcium hydroxide, and I'm going to let you be a doctor and decide that for yourself. I crinkled the cone there. Happens. So Lindsay is going to hand me another cone, and I'm going to see if this goes down to length. Now this one's calibrated, and so I want that to match where my apex locator was, and that one's right there at 19. And there's my working length X-ray. So that's got perhaps the resorption I was seeing on the end of the root. Cone is down to length, and this puppy is not draining. Didn't drain during, didn't drain before. Had a history of draining from the patient to me and from the referring doctor, and was left open. So that's what we know. So I'm going to go ahead and do obturation now. Remove this cone. right. So 19 millimeters here. Let's do a little paper point dry. It's kind of crinkling down there. And again, it's not wicking anything out of that either. And arguably, it may have gone out a little further than my length. And I'm just going to go until it's really not any moisture left inside that. And then when I'm comfortable with that, I'm going to do an injection technique. I'm going to inject the sealer. Choices of sealer can vary. Make sure that puppy is dry. Lindsay's over there, and what she's doing is she's loading up the sealer. And I'm using a Navi tip, and I'm not actually going to bind this needle. I'm just actually putting it down passively to where the needle wants to bind, and then just sort of backfilling. I'm probably definitely using more sealer than I need to, but it makes me feel better. And then I'm placing my cone, watching those marks along that incisal edge, and I'm right there at 19 millimeters. And then I'm kind of doing just a modified continuous wave. I'm not really going down to the terminus. I'm actually just taking it down to where it wants to bind and searing it off, and then doing a down pack. And of course I can worm vertical on top of that now. If I feel like I've removed too much sealer along that way, I can apply more sealer. You can see sealer is still coming out during that backfill. And pretty quick. So we're 25 minutes into this case right now, and just kind of gonna finish this thing off. Now, you can temporize, you can restore at this point. Get it nice and clean. A lot of times I'll actually take a microbrush in there and clean up any remnants with a conditioning agent or just isopropyl alcohol. All right, so let's go ahead and just clean up any of the remnant sealer here. Kind of blow it out. I'm using isopropyl alcohol right now, so it gets it nice and dry. And the request from my referring doctor in this case was to temporize. So I'm going to leave him a breadcrumb, also known as a sponge, not cotton. Put that in there so he can find his way back into that access. Like I said, he did a really good job with his access. I actually just lifted it up to the incisal edge just a little bit more. Let's pack that sponge down and place the temp. All right. Okay, so we're going to play with this just a little bit more and then remove the rubber dam, and let's see what this thing looks like. And then I want to go back to the vestibular swelling. Just going to get another visual of it, and I want to know if it decompressed or drained, although I perceived none of that during the procedural instrument. So, experience of the GentleWave. So, let's kind of clean this up. Let's make room. I do use a Nomad and a digital sensor. I'm going to just kind of remove some of this flashing around the access here. Over here is just some remnant caulking, some flashing. Let's just kind of clean that up. And we'll go ahead and rinse all this clean for the patient here. All right, so the x-ray, you can see, you can appreciate that kind of ribbon, kind of the double canal shaped. I use the 3D shaper followed by the GentleWave. A little bit sealer extrusion, all kind of makes sense, temporary, and everything looks good. But what is this content? So let's take a look at it. When I think about this, I'm going to pause this for a second and just kind of describe this a little bit. I threw this graphic up because a lot of times the body doesn't lie, and infection likes to sit in facial spaces. And the boundaries of those are oftentimes points of origins and insertions of muscles, facial muscles. Now again, this is depicting the muscles and the lip is over the bone, but if you could see through it like this image is showing, those origins and those attachments are actually the boundaries. And so it kind of makes sense that, you know, the mental Freeman isn't the boundary, it's the muscles, and that's why we had the Mickey Mouse type swelling going on there. And this kind of depicts where the points of origins and insertions were of those muscles. So if you look here, let's get this into focus, you can still see those same kind of Mickey Mouse blisters that are under there. They are not indurated, they are fluctuant. But what I want to do is try to see if I can release some of that right now. The patient did report tightness and swelling there, and so for me, I'm going to respect those borders. I'm not going to pierce through a muscle. I want to go in. I'm just going to use an endo explorer and get down into that facial space. And certainly you're seeing some fluid come out here. And you can debate whether that's from my anesthetic and it just stayed pooled in that facial space, or if that's purulence or serous or edema. I don't know yet, but I can still feel content in there with my fingers. And so I'm taking that explorer and I'm just actually starting to trace into that pocket that I showed you on the graphic of where those muscles are. And I'm just going to kind of go to those borders in that pocket, right above the mental tuberance right there. And then, you know what? This is where Dr. Pimple Popper and I have something in common. Okay, so blood. Ooh, what was that? It's kind of satisfying, I'm not going to lie. Well, let's see what comes out of this thing. A little piece of granulomatous tissue in my mind. That's what I'm identifying this as. I'm taking kind of a larger gauge, 27 gauge metal tip, and I'm actually rinsing this out with Paradex. And I'm following along those borders, and I'm going to see if there's any other little pockets or nodules in there. This might be a little bit of elastic tissue or even some periosteum. I feel like I'm through that and down to bone. And now I'm actually getting some release. Like I'm actually feeling that fluctuant tissue release and come through that little drainage. And there's the mass. And, you know, whether you want to call this a cyst or granulomatous tissue, either way, I know the tissue is going to respond quicker if I do this than sort of let it just stay static there. Static environments are never fun for patients, and they have a hard time resolving. They will resolve in time, and I would agree that doing nothing is an option. But doing an IND is also an option. And getting this out of that space is very useful and very helpful for the body to recover. Especially when I didn't get anything out of the tooth. My mind's always jumping to this, and I'm going to let those demons out. Not really doing blunt dissection, like I said. It's essentially just an explorer. And now what I'm doing, once I feel that fluctuant mass is gone, I'll lift the lip up, and that you'll almost sense a little air pocket that develops. And that's when I know I've reached my end point. That's when I know I've sort of debrided or debulked the fluctuant tissue. And now what I'm doing is just doing compression. I'm just putting compression on it. And once I've lifted up, got the air pocket, I can feel that there's no more fluctuant tissue masses in there. I do pressure, and then I'll just put a gauze underneath the lip just so the tonus of the muscles will actually help keep pressure on it. And I usually wait 5 minutes. And but I'm not going to try to recreate that little air pocket once I've done pressure. So I'm going to wrap a gauze in there. If I do, I'll just kind of try to express out the fluid. So I lifted it a little too much to my liking, felt like I got a little bit of rebound going on there. So I'm going to try to not lift that pocket up. But you can see nothing else is draining underneath there. So once I reach that end point, I'm going to pack the gauze, kind of lift the lip up, kind of like you're packing, and packing tobacco, but it ain't tobacco, it's gauze. And then just put that pressure. And then, you know, we have, I'm going to pause for a second. So we called patients right after, and we called this patient right after, and pain was minimal. In fact, didn't prescribe more antibiotics and didn't give her I gave her a painkiller and told her to take it if she needed it. Excuse me, she did not take it. So 3 days later, I got the itch. I'm like, I got to see what that looks like. And so it was over the weekend, so now Monday comes around. So 3 days later, I had the patient send this picture to my phone, text me a picture. You can see there's no bruising, there is no opening, and to her report to me, absolutely recovered and gone that quick. And that's my argument as to why you should drain. So hopefully you like this case. I think it's a great experience to learn the art of the IND, to master facial spaces. And hopefully you find this somewhat useful. So remember to subscribe to us. If you want, just tap that bell and you'll get notifications of episode number 8. This was number 7.